Good afternoon, ladies and gentlemen. Our webinar is beginning. I'm Steve Love, President, CEO of the Dallas-Fort Worth Hospital Council. We want to thank you for being here today for this educational webinar. It's hosted in conjunction with Hall Renda, who's been a longtime associate member and sponsor of the Dallas-Fort Worth Hospital Council. Today's topic is very, very timely, especially what we saw last night. The change is coming, the impact of the 2021 physician fee schedule and the changes on the RVU compensation models. Hall Renda serves the hospital and healthcare industry throughout North Texas and is one of the nation's largest law firms focused on matters specific to the healthcare industry. They have a team of healthcare attorneys that are dedicated to all their clients, not only across the nation, but also here in North Texas. Today, we're delighted that we've got four Hall Renda experts that are going to discuss the Centers for Medicare and Medicaid Services announcement of the 2021 Medicare fee schedule proposed rule, which, as I said, we had news on this last night, and it impacts hospitals employing physicians and compensating them with a productivity model. We're delighted that we have four excellent speakers today: Carrie Dutra, Wes Sala, Reagan Tankserly, and Keith Duggar, and we welcome their presentation. We know it's going to be very meaningful and educational. So it's my privilege to now turn it over to Keith Duggar.
Thank you, Steve, and hello, everyone. We really appreciate you joining us today. We talk about some very recently finalized changes to the 2021 Medicare physician fee schedule. As Steve mentioned, those final rules were dropped last night. And so we think it's a pretty timely presentation. These changes, which affect the calculation of relative value units and the conversion factor used to calculate Medicare payments for certain E&M codes, are likely to impact physician compensation formulas that are based in whole or in part on a physician productivity as measured through wRVUs. Walking you through these changes today are my fellow Hall Renda attorneys, Wes Sala, Carrie Dutra, and Reagan Tankserly. Wes practices in our Milwaukee office, and among his many areas of expertise focuses on physician compensation arrangements. Carrie practices in our Raleigh office and specializes in regulatory and compliance matters with an emphasis on fraud and abuse and physician compensation matters. Finally, Reagan practices in our Indianapolis office and specializes in regulatory matters with a heavy emphasis on reimbursement and payment practices. With that introduction, I'm going to turn things over to Wes to get you started.
Thanks, Keith.
Right. Thanks.
Oh, go ahead, Carrie.
I was going to say, thanks, Keith. I can start off by walking you through, as Keith mentioned, and I'm sure you're all aware, CMS finalized the final 2021 Medicare physician fee schedule yesterday, which included in it the finalization of CMS's previously proposed wRVU modifications for certain commonly used E&M codes. The finalized wRVU valuations, which you can see reflected in the table on the slide, result in significant inflation in the wRVU credit attributable to common E&M services. The greatest impacted of these are the services for established patient codes. They're receiving the greatest impact, with percent increases ranging anywhere from about 28% to 45% of the previous wRVU value attributable from calendar year 2020. Similarly, new patient codes are seeing percent increases as well. Those are slightly less at about 10%. The new wRVU valuations, in addition to those, CMS added two new E&M modifiers. The first is G2211, which was previously known in the proposed rule as GPC1X. CMS added this modifier to account for the complexity, particularly of primary care services, and the additional resources expended by primary care providers to provide longitudinal and holistic care. In the final rule, CMS provided further commentary on this modifier to clarify that it represents time that's not typically and traditionally encompassed in a primary CPT code, but encompasses time expended by practitioners for things like patient education, care coordination, and care collaboration. The second modifier is G2212, which CMS added and clarified for prolonged visits that extend past the traditional time allotted for patient care visits. With that, Keith, if we move to the next slide. In addition to the wRVU modifications you just saw, CMS also finalized its budget neutrality adjustment to the fee schedule conversion factor. The finalized adjustment resulted in a decrease of about $3.68 to the current conversion factor, leaving us with a conversion factor of about $32.41 for the 2021 calendar year. It's important to note with this that the scope of the conversion factor adjustment is limited to Medicare and is not going to be applicable to private payers, though we may see some commercial payers follow Medicare in terms of reimbursement rate and the impact of the conversion factor. Keith, if we move on. So what does this mean in terms of impact to provider compensation? As Keith mentioned in his intro, we expect the most significant impact to be on compensation models that are based on wRVU productivity. The impact and the magnitude of such is likely to vary by specialty, with specialties that heavily use E&M codes in their practice. We're thinking here primary care specialties and potentially some specialties like oncology that have heavy care collaboration and coordination are likely to experience the greatest impact from the wRVU modification. This might mean that going forward into 2021, physicians will see increases in the credits received for their wRVUs with potentially no actual increase in their productivity. Other specialties are likely to be a little bit more insulated from the wRVU modification, but across the board, we expect impact from the budget neutrality adjustment that lowers that conversion factor. In this sense, we've seen some sources anticipate reduction in collections anywhere from 3 to 8%, depending on the services and payer mix involved for the provider. Lastly, one of the main impacts will be on compensation survey data. Given that survey data typically lags about 1 to 2 years behind what's going on in the current industry environment, we don't expect to see any of these new wRVU modifications and their impact on compensation reflected in surveys until 2022 or later. So that's important to keep in mind as folks are looking at surveys in terms of calculating and analyzing physician compensation. And with that, I'll turn it over to my colleague, Wes Silla, who will talk about some takeaways and what employers and systems should do.
Thanks, Carrie. Yeah, as Carrie said, and kind of moving on to the next slide, what should employers and systems do as they contemplate their arrangements with physicians? When it comes to provider arrangements, as Carrie said, there's likely to be an increase in the amount of RVUs that are produced, potentially across the board. But with the budget neutrality piece of it, it will also kind of be offset by decreased amounts of reimbursement on that end of things for the Medicare services. And so, as Carrie said, we're going to have salary survey physician compensation data in 2021, 2022 perhaps, and this may not kind of bring us to a normalization all the way through 2023. That does not quite line up with what has historically been the case. There will be increase. So in our conversations with organizations as they've considered how to approach these new, this new final rule, there's been a number of options that have been considered as to how to move forward, ranging from moving forward with new, completely implementing the Medicare physician fee schedule for 2021 by some organizations. Some organizations taking the approach of relying on, 2020 Medicare physician fee schedule RVUs when it comes to determining compensation for physicians. Some organizations, coupled with those changes, are considering how they might, impact their comp per RVU amount to ensure that compensation kind of normalizes. And some organizations are just kind of, moving full steam ahead without any changes to the comp per RVU amount. All of these approaches are going to depend on each organization. It's why, as employers and systems consider what the best approach for their organization is, they should look at their own physician contracts to see what they say. A number of organizations build into their physician contracts what methodology would be utilized when it comes to Medicare physician fee schedule. For instance, there may be language in physician or provider contracts that contemplate the most recent or most current physician fee schedule. There may be other ones that specify the specific Medicare physician fee schedule that will be utilized to determine compensation. Along those lines, whether that can or can't be changed is going to depend on an organization's specific approach. And so these are going to be important questions to consider as organizations move forward with trying to determine what works best for them. Because moving into 2021, what we anticipate is the physicians that move on to the 2021 physician fee schedule without any adjustment in their comp per RVU amount are going to see increases in the amount of compensation, depending on their specialty. It could be 10, 20%, depending on the number of E&M services they do. And so they will increase the number of RVUs correspondingly for those physicians on productivity models. That will likely increase their compensation as kind of a corresponding percentage if there is just a flat comp per RVU amount in the physician's compensation models. But then when we look at the 2021 physician compensation data, that data is going to be based on 2020, which as many of you listening probably, we all kind of accept that 2020 is kind of an aberration year with COVID and how that's impacted everything. But nonetheless, the comp per RVU amounts, the median RVU, 75th percentile RVU, all the data that's in the 2021 physician compensation salary survey data is going to be based on 2020, just like 2020 was based on 2019. So there's going to be a lag. And so that means that physicians that are not adjusted in any way such that they move on to the 2021 physician fee schedule and have their comp kind of flat as far as the comp per RVU amounts go, are likely to see their compensation percentiles rise in the data, which will also include a corresponding rise in the number of RVUs they produce, which will help kind of offset that a little bit. But the challenge will be physicians will not be bringing in as much money off the Medicare physician fee schedule with a lower reimbursement amount. So there will if there are no adjustments made, what's likely to occur is that there is likely going to be the case that physicians make more money, bring in the same amount of revenue, and so their collections will stay flat, which will mean that their revenue will, or their compensation will exceed their collections, which at least historically has been utilized by the government and QTAM whistleblowers to bring cases under the Stark Law as a potentially problematic situation. Now, under the new Stark rule, there is some language that contemplates that it is not necessarily a problem if a physician brings in or receives more money than their collections, but it is a factor that has been considered in many of the complaints in the past, and so something that organizations should be on the lookout for. And additionally, outside of we have the employed physician context, and so in those employment situations, we're likely to see the compensation increase when the physician fee schedule is the most current physician fee schedule numbers, and the comp per RVU amounts are not changed. But then when we're talking about more independent contractor arrangements or arrangements for physician groups, their revenue is likely to stay flat, or would stay flat under the neutrality piece of the Medicare physician fee schedule final rule here. And so this could lead to a difference in compensation between independent practice providers and those employed providers, depending on what those contracts contemplate. And so organizations, as I said before, should consider what their contracts say. They should consider how quickly any changes could be made. They should consider bringing physicians into the fold to have discussions as to best approach moving forward, because as everyone has probably experienced at some time or another, compensation is it's a very important piece for physicians, and so it's often helpful to include them in discussions as to the best way to move some of these forward, because there will be risk if organizations move forward with the new physician fee schedule without making any adjustments as it relates to the comp per RVU amounts. So organizations should really consider that piece. I think Reagan may have some thoughts on the reimbursement piece. If you'd like to go ahead and take over, Reagan.
Yes. Yep. Thank you, Wes. So from a pure CMS reimbursement fee schedule standpoint, these are very significant changes to E&M services. These are the most significant changes we have seen in 30 years related to E&M services, which are very prevalent. It's your office visit. It's when you go see your primary care physician, or it's when you have an office visit with a specialist. So these changes from a pure CMS standpoint have really been touted as something that were expected to be welcome, because by adjusting the RVUs, it is giving more credit to the E&M services viewed as the physicians who are providing primary care services, maybe chronic care management services. There was a concern that over the years those codes have been potentially misvalued based on the weights, based on then the median compensation for primary care physicians as opposed to specialists. And so in adjusting the RVUs and at the same time increasing the just pure fee schedule reimbursement rates for many of those E&M services, this was a push by CMS to recognize the value of the patients over paperwork and spending more time with your patients. That goes hand in hand with some of the documentation flexibilities to make it easier for physicians to spend their time in discussion seeing their patients. So that was the goal in the CMS, the adjustments to the E&M related purely to the rates and then the RVU adjustments. What took everyone by surprise then was, because of that new budget neutrality requirement, was the fact that they lowered the conversion factor. And that's where now all of the uncertainty comes from. If we were just looking at this as in a pure vacuum, we would see, increased RVUs for the E&M services. We would see increased payment rates. That's all great. You expect that if your productivity stays the same, your compensation or your revenue in the door generated from those codes may go up based purely on just looking at those services that were revalued. But what is significant then is what will be the overall impact for organizations that have many, many different providers and specialists within their physician groups from a compensation standpoint. And that is why we're still in this limbo area of, well, what will this mean long term if we have winners and losers anytime there is a rule like this announced where you have a budget neutrality adjustment and a conversion factor that may go negative. You're going to have some providers who are then going to be bringing more revenue in the door, and that may be impacted then by their compensation. At the same time, you may have others whose productivity stays the same, but because of that conversion factor, maybe they're bringing less revenue in the door. So an important takeaway for me, looking at this from a reimbursement standpoint, is because the changes are so significant on the E&M side, what are commercial payers likely to do with this? I mean, again, these are Medicare changes. That wRVU system is the basis for the Medicare physician fee schedule, but we know that one, other payers may adopt that type of model, and two, a lot of compensation arrangements are based on that RVU. And to Wes's point, do the contracts just track every year, follow whatever Medicare is doing? Is there some other consideration within the compensation? So I think what we need to be mindful of is, one, the impact directly on the fee-for-schedule Medicare payments, but then how will our other payers then maybe adopt that, especially when we're seeing such a significant change, not just from CMS, but on the AMA, the way they've done the code descriptors differently for E&M services beginning in 2021, what may happen with the commercial payers following that. So it's a lot of pieces to put together to a larger puzzle that we'll have to wait over time to see how those other payers will adopt perhaps these changes made by Medicare.
Right, Reagan, thank you very much. The last slide that we've got, it really, what's kind of funny about this is we were preparing a presentation about the proposed 2021 Medicare physician fee schedule, and the final regulations were dropped last night, as we mentioned earlier. So we scrambled a little bit to update the slideshow, but essentially those final physician fee schedule rules, and particularly that includes the changes to RVU calculation and conversion factor on these E&M codes, was finalized last night, or at least the final regulations were issued. There was some pushback by the stakeholders, as you all well know. As Reagan went through it, we liked the fact that there was going to be more recognition of the time spent on some of these evaluation and management services, but the corresponding budget neutrality reduction was not very appreciated. There was pushback. We thought maybe we would that CMS could pull those back and not finalize them, but they went ahead and did it. So now the industry has to live with that. And so the recommendation is really, to the extent that a system or a medical group, a physician employer, has not already done so, really need to look at that and analyze the impact of the final rule on your financial bottom line, to really understand, is this going to create a problem? Do our contracts provide for compensation in a way that the increased number of RVUs will not be offset by the reduction in conversion factor in our own agreement? Do we have some type of saving provision in the agreement that allows us to have a maximum cap on compensation? Some of these other things that Wes talked about. But a system or an employer cannot do anything until it understands what is the potential financial implication of this. And as you are also aware, CMS dropped some really big regulations on changes to the Stark and anti-kickback statute rules about a week and a half ago. So the industry is being hit by a lot of changes to regulations that define how they get paid for services and how they have compensation relationships with physicians and others. So we really recommend that you read the rules, that you understand their impact, and to the extent that you have questions about that, we would ask you, feel free to reach out to us or your legal counsel and make sure that you're understanding all of the legal ramifications of that. We also provided on the slideshow a link to that final physician fee schedule rule. You can see the link there in the slide. Really, this is a very focused issue, and there's a lot we can say about it. I think appreciate Wes, Carrie, and Reagan putting in their thoughts on there. We hope we provided you with some good information to take home and think about. We welcome any questions. Again, this is a fairly short presentation based upon the specific issue that we were dealing with, but if you have questions now, glad to take those. If you have questions later, we've got contact information on here that you can feel free to reach out to us, and we'd be happy to talk to you about it.
Hey, Keith, we do have a question that just came in here. How do these changes affect the ability of an organization to rely on compensation survey data to assess the fair market value of physician compensation?
Wes, I'm going to lean on you.
Sounds good. So I think, at the end of the day, under Stark, the AKS, the regulatory framework we have, fair market value opinions, evaluation consultants, and still looking at physician compensation salary survey data, going to independent evaluation consultants is still going to be best practice, even in spite of this. We have a number of contacts in the valuation industry that, they are also contemplating these changes, proposing recommendations as to how they think organizations might best move forward. As we've kind of talked about already during this presentation, the biggest impact is going to be on physicians that have a comp per RVU methodology. At the end of the day, that is where, this is going to really impact physician comp and how that lines up with the salary survey data. There are going to be some potential benefits for those physicians that are on salaried amounts. And we've actually seen some organizations reach out to us to discuss moving to salaried amounts over the next couple of years to try and get some stabilization, kind of utilizing historical compensation to set compensation for the next couple of years while these RVU changes kind of bear out. But these changes at the end of the day aren't going to change what organizations should do for best practice. The best practice is still look at the salary survey data, see where your physicians align against the market, recognizing next year and potentially the year after that there is going to be some discrepancy between what the salary survey, RVU amounts are, and because of the 2020 physician fee schedule versus the 2021 physician fee schedule, but still utilizing that data to kind of place your physicians against the market. So it's still a best practice. It's still what we recommend organizations doing. They should look at it internally when setting compensation. Evaluation consultants will continue to look at that data as they do their independent FMV opinions and valuations. And so we don't think that this is going to change, whether organizations should rely on it, because, the industry is going to be aware with this final rule that there will be changes to 2021 that don't align it perfectly, but they are going to account for that when there are either FMV opinions or they're just asked questions about this stuff. So it still remains best practice.
This is Steve. We just got another question, and I know you touched on this, but this is really a pretty good question. In y'all's opinion, do you think we're going to have big shifts in the RVU allocations in future years, or do you consider this a blip?
This is Reagan.
Go ahead, Reagan.
I'll just comment quickly. this has been kind of a long time coming, at least for the E&M, and so I wouldn't necessarily expect it to continue as a trend if it took this long for there to be any kind of a significant change to E&M services, and that's kind of a crystal ball approach. But at least if we're contemplating just the E&M services, which seem to have a lot of the RVU change to them, since it took this long to get there, I would not expect that to be an every year occurrence.
Okay, thank you. Another question we've received is, what is the anticipated impact on reimbursement for physician services as a result of the change in the conversion factor? Will some specialties, in your opinion, be hit harder than others? What are your thoughts?
Yeah, I think at the end of the day, there's going to be an impact more so on the specialty providers. There's going to be, those ones are going to be hit a little bit harder by the reimbursement, as you know, depending on if you're a proceduralist or if you do a lot of E&M codes. You know, the more E&M codes you do, typically more associated with primary care, the more likely this is either going to benefit you or keep you stable. On the flip side, if you're a specialist and you do a lot of procedures, less E&M services, it's going to impact you probably a little bit more towards stability or the downside. Now with that, as I've been going through the final rule, I know that they have been making some adjustments to some of the more some global pieces. It's not just limited to E&M by themselves, and they have also taken into account how E&M impacts some of some other services as well. I don't know if anyone else on the panel here has thoughts on it as well.
So this is Carrie. The only thing I might add, Wes, is that reimbursement, particularly offset by some of those new modifiers, may hit some specialties that we wouldn't see particularly right in the primary care realm, but thinking about services, specialty services such as oncology that might be able to use some of those modifying codes in addition to some of the specialty services they provide for care coordination and collaboration, particularly with treatment plans like a chemotherapy plan or otherwise, that those modifiers may be applicable to their service lines and may impact some reimbursement in those fields as well.
Good point. We've got some more questions coming in. These are really good questions. If we decide to make adjustments, should we make them right away or wait? The reason our physicians typically don't hit their productivity bonuses until towards the end of the year. Do you have thoughts on that?
So I think we would recommend looking at that right away. The 2021 physician salary surveys are not going to be, they're not going to provide answers on that because it's going to be based on 2020 data. So I think it's a good step to consider right away, because these can, you know, some of these processes play out in a more long-term fashion. When we engage organizations, or organizations engage us, I should say, to help them kind of work through some of these, we know that the process can take months. So the sooner organizations start considering these changes and you know, potentially modeling out how this is going to impact their organization, so they can have a feel for what they might want to do with regards to their, you know, productivity-based physicians if they pay a comp per RVU amount. We'd recommend probably considering it now and thinking about that now, as opposed to waiting towards the end of the year to try and set it in motion. So everything, by the time the end of the year comes and those productivity bonuses are paid out, you know, it's kind of already been set and everyone kind of knows where they're gonna fall.
Yeah, that's a great point. And Steve, I'll just add, remember that under the Stark Law, your compensation methodologies have to be set prospectively. So the longer you wait to make modifications to it, the more constrained you're going to be on the impact of those changes. So just keep that in mind.
Great. We got some other good questions rolling in. Let me see. What do you think, in your opinion, this change is going to do as far as impacting hospital-based providers? Example, hospitalists, ER, critical care providers. Any thoughts on this change impacting those hospital-based providers?
Yeah,
go ahead, Keith.
Well, I was just going to say, I think these are professional fees that we're talking about. And so anybody with a high volume of evaluations are going to be impacted by it. There are specialists, and I think Wes, I'll let him get a little bit more into that. The effect on specialists is going to be particularly pronounced to your primary care, and so it very well could have an impact on that. Wes, what are your thoughts on it?
Yeah, I mean, I was going to say, when it relates to those hospital-based physicians, what we see what we've seen more frequently in the industry, and it's not wholesale across the board. When it comes to hospital-based physicians, some of them tend to be more on an hourly basis than some of the other providers. So for some, this won't impact them if they're on that hourly methodology. I think if they're on a comp per RVU amount, they are probably likely to be closer to some extent into the primary, how it impacts primary care a little bit. But I don't know if it's going to be very individual specific and to their own specialty, whether they be, hospitalists, ER, critical care, but also what type of procedures they do or how many procedures they do. Obviously hospitalist is a little bit more straightforward, but if you get into critical care services, you might end up with some more procedures than you would for hospitalists. So it's going to be very individualistic. And so that's why I think at the end of the day, organizations are best served, if you have historical productivity on your physicians, and you can, kind of assess the 2020 fee schedule against the 2021 fee schedule. I think that's, it's a great idea to do, just to see, if you were to put everyone on the 2021 fee schedule based on their 2020 year, you'll have a sense as to where they'd likely end up.
Good point. Another question, do you think that this change will make some healthcare organizations return to the collection-based approaches?
It's a good question. It's always hard. It's always hard to know where these are going to necessarily lead. I think there's been such a transition, at least, and I'll pass it over to Keith after my thoughts here. But I think we've seen over the years there's been a transition from collection-based methodologies to RVU-based methodologies, especially and then including how hospitals and systems relationships with their independent providers. Some of them don't want to. The independent providers don't want to bill and collect on their own in some places that we see, and instead would much rather get paid a RVU amount. I think the uncertainty in the current year, or in the upcoming year, 2021, might lend itself more so to just trying to find some sort of stabilization, at least for hospital and health systems, and their arrangements with physicians, because I think they're going to want to have some certainty, the physicians are, as to where their comp is going to be next year and the year after. Just knowing that this is a significant change, and as Reagan said, it's been many years in the making. but it will impact compensation, and each specialty is just going to be impacted differently. And so I couldn't say whether it will or it won't. My guess right now would be that physicians are going to want some certainty. So maybe there will be some sort of a couple year period where they try and just find a stabilization amount, saying we're going to pay physicians X amount of dollars based on where they ended up last year. But really, it's a crystal ball that it's hard to prognosticate where it's going to end up. But I don't know, Keith, if you have any additional thoughts.
No, Wes, I think you're exactly right. I think given that this is not a frequent occurrence, I don't know that it's going to be the impetus to switch back to collection-based. And I do think kind of that certainty factor is what physicians seem to be looking for, things that they can control. The actual collection of their services is not something they control, but they can control to some extent how productive they are. So I don't know that it's going to be in and of itself the impetus to switch back to those collections. And sometimes a collection-based compensation can create its own types of risks and drawbacks. So I would be guessing if I gave you a definitive answer, but I think for the reasons that Wes talked about, I don't know that it will result in that wholesale type of a change back to a collections-based compensation, particularly for employed physicians.
All right. Speaking of collections, here's a unrelated but related question. If we have a physician that is earning more than what is actually being collected, are we at risk of a Stark law violation?
I think
Could you repeat that one? Oh, could you repeat that one more time?
Yeah. If we have a physician that is earning more than what is actually being collected, are we at risk that we may be violating Stark law?
And I think that's something that Wes.
Go ahead, Keith.
Oh, go ahead, Wes. Yeah.
I was just gonna say that it's one of those age-old questions. If it's problematic, if it's not, I would say, historically speaking, when valuation consultants look at collections data, it's going to be very specialty specific. It's not as simple as saying, are the collections less than what we're paying out? In certain specialties, it's expected that there's going to be a quote unquote loss on the professional side of things. In other specialties, if there is a loss, that's a little bit more unexpected. And so it is not per se problematic. It is something that a valuation consultant would want to look at, and it's going to depend based on specialty. And as we kind of talked about a little bit earlier, in the new Stark regs, there is some guidance that suggests that collections that are less than the compensation that's paid out is not going to be per se problematic, and it's not going to tell you that the arrangement's not commercially reasonable. So whether there is or isn't a Stark issue is going to be it's going to be a very individual analysis. And so, the arrangement may warrant more consideration, but it is not going to be necessarily problematic on its face. So I don't know, Keith, if you had additional thoughts.
Yeah, no, I was going to reference back to what you had talked about earlier, but I think with the new Stark laws, and particularly what is commercially reasonable or not, there seems to be more flexibility and an acknowledgement that you may lose money or you may not be able to cover with collections what you're paying out to somebody, but it's going to be other circumstances surrounding that relationship that really govern whether there is a significant Stark factor, a significant Stark risk or not. I would generally say that if your collections are not enough to cover the physician's compensation, that warrants further review, as Wes suggested, and either you're getting a compensation specialist in there an analyst to look at it and to let you know, hey, this is reasonable or it's not reasonable, and you're looking at other factors as to why you're doing that. If you're a hospital and you have a significant population that requires a particular type of service, but you're in an area that is difficult to get somebody to come in there, you may have to pay that physician more, which would potentially lead you to in order to meet that community need. And so that may lead you to paying more than what you collect on it. Hopefully that answers the question, but it is, as Wes suggested, it is a case-by-case analysis situation.
Got it. How can we build protections into our future contracts for these changes? Should we, as the employer, have to approve usage of any updated fee schedule?
So I think that's gonna, it's gonna kind of depend on what your current contracts include. I think this change is kind of a great, it's kind of a great instigator for looking at your own contracts and seeing where there might be some room for changes, where you might want to make updates to contemplate, significant changes such as this. As Reagan said, this has been a long time in the making. So whether or not we see any real change or significant changes in the near future, it's hard to say. It may not happen for a while again. But when we factor in this change this year, in increasing RVUs for some physicians, probably a significant amount, and then you couple that with what we found with the COVID pandemic, the combination of the two, I think, really are a great starting point to kind of reassess your contracts, seeing where you might be, maybe build in flexibility if possible. Obviously, depending on whether you can or can't build in flexibility or how you can go about doing that is going to be very organization specific. But this is, I think, a great point to really assess those contracts, see if you want to set the physician fee schedule. We're using the 2020 physician fee schedule, or building in certain provisions in the case of some significant regulatory change or something along those lines. This could be a time to re-examine that and think about what else, how you can kind of future-proof your contracts a little bit. So I don't know if anyone else on the panel has thoughts.
No, I think that's right. And I think, one of the things that I look back on these productivity contracts is, usually the conversion factor that you use as part of your compensation formula has always been kind of within the control of the employer. You look at what are the surveys say, how are we getting into fair market value, but it is not necessarily typical to use the Medicare conversion factor. You utilize a different one, but the calculation of the RVUs really has not, at least in my opinion, been in the control of the employer. It's just you've looked at how RVUs are calculated under the CPTs and using the Medicare guidance. And so I think what it does is it tells you, listen, there are external changes that can affect how much you pay, or you can affect those compensation formulas. So it's important to look at what are those protections that we can incorporate in there. And those protections may simply be, Steve, I think as you initially suggested, do we put in that changes to the way RVUs are calculated and the conversion factor are within the discretion to accept or reject of the employer? There may be certain kind of dollar caps that you would put in there, but ultimately it's going to be dependent. Again, I hate to keep saying it's a circumstance by circumstance basis. It's going to be dependent upon the makeup of your practice, your physicians that you compensate, their specialties, what type of an entity you are, what type of compensation formula you incorporated. Is the entire compensation governed by a productivity formula, or is that just a bonus structure? There's going to be so many factors that go into that that there's not a one-size-fits all for how you address potential uncertainty.
Right. We got 3 more questions, and in respect to your time, we'll go through them pretty quickly here. But if we go into the new fee schedule arrangement, and the physicians are allocated more RVUs, what do you do to suggest how we, one, document compliance, as we think our primary care docs have historically been under market. Do you have any thoughts on that?
Yeah, I think there are kind of two schools of thoughts when it comes to these changes here. One is trying to keep physicians where they've been historically. That's one school of thought. One school of thought thinking, there's a budget neutrality piece of it. So the goal here would be to keep physicians largely revenue neutral or neutral in compensation. On the flip side, there are people, and that's why some organizations are probably going to take the approach that they're just going to implement the 2021 fee schedule and kind of, move forward with it without, significant changes in their comp per RVU amounts, and result in higher compensation to their primary care physicians, because there are people that, that there is a segment of the industry that are saying, and we see organizations contemplating this, that one of the reasons the government proposed these changes is to recognize the value of primary care physicians and the time it takes to coordinate care and all that stuff. And so paying them more is an appropriate approach moving forward. So documenting it going forward, kind of seeing where they've been, engaging, depending on how much of an increase it's likely to be. If you're talking $20,000, if you're talking $100,000, those can be two different, significantly different outcomes. But, assessing where they were last year, documenting how you got to the next point, it might be a good idea to consider valuation, engaging outside, outside compensation services to kind of assess your comp plan or your approach to compensation to ensure that it's aligning with, the industry. And then, it's always a good practice at the end of the day to get, some sort of outside FMV opinion or FMV assessment to kind of show that you are, the industry accepts where you're paying your physicians. So for those that are going to move forward with the new physician fee schedule without making any changes to a comp per RVU methodology, it probably is a good practice to consider having your comp approach assessed outside the organization, just to ensure that it aligns with industry norms and is consistent with FMV.
Good point. Here's a question. If we want to adjust or decide to adjust our conversion factors in our contracts, would you recommend that we do it on an individual basis or by specialty or across the board?
I think, and Wes, you can certainly chime in. I'm not a big fan of the individual basis. I think that there are, when you're looking at comparable compensation surveys, generally it is done more, you look at it from a standpoint of specialty focus. Certainly you can do it across the board. Each practice, each organization is going to be different, and it's going to depend on where their conversion factors were to begin with. And it's also, I can't stress enough, it's important to prospectively understand what the anticipated effect of this will be on the organization. As Wes mentioned, it could be, for an individual physician, it could be $10,000, it could be $100,000 difference on compensation. So before an organization gets in there and starts making wholesale changes to their compensation formulas, it's imperative that they get out there and that they assess what that prospective potential effect is going to be before they start making that change.
Yeah, I wholeheartedly agree with what Keith has said. I think we would recommend at the lowest level a specialty basis adjustment or an organization-wide adjustment, but the individual adjustments, it just gets more tricky. If you take more of a specialty approach, I think generally that's probably going to lower the risk versus an individual specialty or an individual physician, I should say. And so I definitely agree that, with what Keith said, that it's specialty or more organizational wide are the two best approaches to kind of deal with it versus an individual physician.
Right. So Keith, here's a great question. You're going to have to look in your crystal ball on this one. Given the apparent pending change in the White House, i.e. new HHS secretary, new leader with CMS, do you predict or foresee any reversal or mitigation of the impact of what we've discussed today, these changes?
Well, it is crystal ball, and I think my guess or your guess, anybody's guess, is as good as mine. I don't think that from what I'm hearing, not necessarily with respect to this regulation, but with respect to other regulations like the Star Community Kickback, I'm not hearing a strong appetite for trying to undo these regulations. The Medicare physician fee schedule, they issue it every year. There are things that are in it that not everybody likes every year. But although it's controversial, I think if there was going to be any makeup, it would be made up in the 2022 Medicare physician fee schedule. I don't sense an appetite for trying to unring this bell before the end of the year, before either the end of this year or at any time in the middle of next year.
Great. I think that's a good answer. Well, Carrie, Wes, Reagan, and Keith, this has been fantastic. This has really been a great discussion. And I thought on behalf of everyone participating, we want to thank you for this great webinar. But Keith, I'm going to turn it back over to you and the team for any closing comments. But thank you for a great program.
Thank you as well. You and Chris, you always set up and host just the best webinars. They tend to be very productive, and it's a great forum. So thank you for allowing us to do it. We just want to wish everybody the best. We know that there's a lot of change. There always is change in healthcare. We know that this type of change, which can have significant financial impacts, are especially hard on providers. We want to encourage you to reach out to whether it be us or your own legal counsel to make sure that you're understanding what the impacts are, and we wish you the best, and thank you for taking your time to participate and listen in on this webinar. And I thank Reagan, Carrie, and Wes for providing some really excellent information and making me look smarter, and just appreciate your time.
Thank you very much.
Thank you all.
Thank you.